this lecture will take us through the final section on the electrolytes and kind of bridge us into the acid-base disorders. That will be the final section of lectures for Chapter 8. So the only electrolytes we really have left to talk about are phosphorus and phosphate and chloride. So let's begin with phosphorus or phosphate. I do have some resources posted on the Moodle page for things like the Merck manual and some other resources to help with the understanding the role of phosphorus or phosphate. However, your book does have some information on it as well, so the majority of the content you hear in this lecture is based on the content that's in the book, but to have a little bit deeper understanding, because I will say the book just gives a little bit of an overview of the abnormal levels of phosphate, and then it talks about it again a little further on in the chapter with regards to the buffering role of phosphate in acid-base balance. But again, those other resources are helpful, so do take a look at them. And when we talk about phosphate, we really have to break it down into what we refer to as organic phosphorus and inorganic phosphorus. So it's the inorganic phosphorus, or the phosphate, which is what HPO4 with a -2 charge is the actual electrolytes that's measured. Organic phosphorus is what we find that makes up ATP, the phospholipids in the cell membrane or in membranes surrounding organelles within the cell, and in the nucleic acids. Now, inorganic phosphate can be used in organic and back and forth, so they're interchangeable. It depends upon the form it's in as to whether we refer to it as organic or inorganic. Normal functions in the body, bone formation, and so we do have a storage of phosphate in the bone, and then as I've already mentioned with ATP and the DNA, RNA, and cell membranes, but it also plays a role in metabolic processes. Certain enzymes require phosphorus, and as I mentioned before, it's also as an acid-base buffer. Losses are in the kidney, and the regulation is with PTH primarily. There's a slide in a previous lecture that covers the role of parathyroid hormonal calcitriol in terms of their role with phosphate. So that's already been covered. If you don't recall, go back and take a look at that a little bit more fully. But in a quick nutshell, remember that parathyroid hormone will actually promote the absorption, along with calcitriol or vitamin D, will promote the absorption of phosphorus in the GI tract, but then PTH will also promote the loss or secretion of phosphate or phosphorus into the urine. Phosphate plays an important role in the buffering of the urine as well, because there's so much hydrogen ions, which is an acid, so phosphate buffers at the kidneys as well and is lost in the urine. So, but PTH is their primary, calcitriol and to a lesser extent in that absorption role, but primarily absorbing it in the GI tract and then promoting the loss of it at the kidneys. So, our disorders, hypophosphatemia. The causes are listed here. Insufficient absorption and prolonged use of antacids is one of the things that can cause this to occur. Any kind of kidney problems, we're supposed to have it regulated and therefore greater loss at the kidneys, but it can be to the point where you actually are losing too much. Whenever we say we're promoting the loss of something, we promote the loss of potassium, for instance, at the kidneys. Keep in mind, we're not trying to get rid of all of it in the body, but that is where we regulate it most significantly. Certainly malnutrition and chronic alcohol use. It affects both kidney reabsorption, and chronic alcohol use is linked very much to malnutrition. Those who are alcoholics tend to not eat properly and get proper nutrition as well. So those two really go together as causes for issues with phosphate levels or not having enough. The manifestations are in your book, so see table 7-8 for that. Once again, you see things like paresthesias, confusion, seizures in terms of CNS function, and it does affect musculoskeletal. But its most significant manifestation is going to be the depletion of ATP. So what you're going to see is when you're in hypophosphatemia, phosphate will be grabbed from the bone and trying to maintain normal phosphate levels. So that's part of where the bone pain comes in. It also affects red blood cell metabolism, so we result in anemia. and in children in particular, it can see skeletal deformities. In adults, it's that bone pain. Again, the bone pain comes from the fact that we start taking from the bone the phosphate that's being stored there in large amounts to try and compensate for insufficient intake or rapid loss, for instance, at the kidneys. All right, that doesn't have to necessarily be rapid. It's just profound loss. It's probably a better adjective for that. Profound loss at the kidneys will wind up having us taking it from the bone. And hyperphosphatemia, again, this can be a chronic kidney disease. So either the kidneys can either fail us by having too much be lost, or the kidneys can fail us by not having anything be lost, and suddenly we're holding on to excessive amounts of it. In hyperphosphatemia, you can also see that there can be some rapid or causes for hyperphosphatemia is rapid ICF-ECF shifts. That exchange can sometimes cause that high intake. And the tissue injury is important. Particularly, we'll see that in burn patients or those that have had massive trauma. When you have massive amounts of cell death, even in hypoxic conditions, that phosphorus then is being released from the cells. The cell membranes break down. All the phosphorus that made up the phospholipid bilayer now are released into the extracellular fluid, interstitial space, and that can cause high levels of phosphate or the levels of phosphate to go high rather quickly. The manifestations, the key manifestations for this, there can be some calcifications, even though the term calcifications often refers to calcium. It is not solely calcium. It can also be, as I mentioned in previous lectures, it can be magnesium salts that start forming, and it can be phosphate as well. But the biggest deal here is that as phosphate levels start to go up, what we see happening is that the calcium starts binding to the phosphate. With that excess binding of phosphate, we actually wind up having low calcium levels. And so a lot of the manifestations that you see for high phosphate are really the same manifestations you see in hypocalcemia. So you have to link those two together very closely. Now, low phosphate does not automatically mean high calcium levels. It's just what happens is there seems to be a kind of a trigger point as phosphate levels start to rise. One way to try and neutralize those excess phosphates is for calcium to bind to it. But again, it's not always necessarily a direct reverse process. Low phosphate doesn't suddenly mean there's an excess amount, and we're not automatically seeing hypercalcemia. This is more a manifestation of what happens after the phosphate levels hit a certain high in the kidneys, particularly when the kidneys are not capable of excreting it. So keep that in mind. High phosphate, think about that binding that starts occurring at kind of at a trigger point. The levels start to get high, particularly if it happens rather rapidly. Calcium will start binding to it, and you see all the same effects of what you would see with hypocalcemia. All right, then we have chloride. Now, there's the chloride in the textbook doesn't fall into the regular electrolyte section, and it's only minimally dispersed throughout the section when you start dealing with acid-base balance. But I want to talk about chloride, particularly in its role in functioning with carbon dioxide transport. So just kind of as a note, in terms of level of chloride, their numbers aren't quite the same as what you see with sodium, but remember that sodium chloride, or salt, which is the way we intake our chloride, is in the form of table salt, that they dissociate once they enter into fluids. The sodium and chloride separate. And we know we've covered a lot of what sodium does in terms of fluid balance. Well, the chloride isn't a fluid factor, but it has some very similar regulation. So aldosterone is still the main regulator for chloride, the same as it is for sodium. And so you see some of the same concerns that you have with high sodium. Whenever you see high chloride, usually that is also an indicative of high sodium levels. So those, although their functions aren't identical, they pair together a lot in manifestations. But one of the important functions then is the chloride shift, and hopefully this is something that you would have covered in A&P2 when you did your respiratory chapter, when you talked about the way that carbon dioxide is carried within the blood, from the point at which it, remember, carbon dioxide is our major waste product from metabolism, and so carbon dioxide can be carried within the red blood cells, can be carried within the blood plasma, and it's converted into bicarbonate. And so we'll spend a little more time on that equation and that process in the acid-base chapters. But this process of what goes on is demonstrated here. So these are the words that take you through. I'm not going to read through the actual steps, but I'm going to walk you through this picture. This is the equation, and again, we'll spend more time with this equation because we use this in determining acid-base balance, and we use that even in recognizing how to calculate pH. So we'll look at that more fully with the next set of lectures. But recognizing, if we look here, these are our body tissues. There's that carbon dioxide that is being formed as the waste product from metabolism. It diffuses into, this is the capillary wall here, diffuses into the blood vessel. Some of it does dissolve in blood plasma, but when it enters into the red blood cell, what we have happening is a switch that takes place. As the carbon dioxide enters in, it combines with water that then therefore forms bicarbonate. That's this is carbonic acid, but then what it does is in that equation of forming carbonic acid, carbonic anhydrase is the enzyme that makes this reaction occur. When that formation occurs, it then quickly dissociates into bicarbonate and hydrogen ions. We need the bicarbonate, it's the major base in our blood. We need that to leave the red blood cell and buffer with the hydrogen ions that are present. Now, hopefully the hydrogen in this particular equation, this isn't the only place hydrogen is found or formed, but the hydrogen here will actually remain buffered within the red blood cell. But in order for that negatively charged bicarbonate to leave the red blood cell, chloride with the equal charge enters in. There's the shift that takes place. And so if I back it up here, you'll see right here that the bicarbonate will move back into the plasma, and it does so, chloride moves from the plasma into the red blood cell, forming what we refer to as the chloride shift. And the bullet point above it here mentions what I said about the hydrogen. It will remain within the hemoglobin, and it helps assist in the removal of oxygen in that process of, remember, hemoglobin's carrying our oxygen for us. So when it becomes oxygenated at the lungs, we need the hydrogen there to help release that oxygen at the tissues for its function. So that's really not a part of the chloride shift, but rather in this equation, that's what happens to this particular hydrogen ion. It's hopefully, as long as the levels don't get too high, that hydrogen can be remained within the red blood cell itself and will help releasing of oxygen. But the chloride shift is that exchange between bicarbonate, the bicarbonate in the equation we see up here, that's produced when carbon dioxide and water bind together. So the shift is where we release the bicarbonate from the red blood cell and chloride enters in. So as long as there's ample supplies of chloride, this shift takes place. This is why the blood plasma is actually at a 7.35 to 7.45 pH, why our blood is slightly more basic. It's because of the presence of this bicarbonate, and this can only occur if in fact there are adequate levels of chloride. So if we have low chloride, one of the most common causes of hypochloremia is vomiting. We tend to lose a lot because with vomiting that comes loss of hydrochloric acid from the stomach. So we lose chloride that way. Some conditions that can cause that, again, anytime sodium is low, since sodium is predominantly brought in with chloride in the form of salt, if we're not bringing in or if somehow we're losing it at the kidneys, chloride will be lost at the kidneys along with the salt. And so hyponatremia and hypochloremia are very closely linked. Diabetic ketoacidosis is a condition that we'll talk at a lot more detail, a little bit in the acid-base balance, but we'll actually hit diabetic ketoacidosis when we do diabetes mellitus, and we do that towards the end of the course. So I won't say a lot about it here other than to say that this is an acidotic state that exists because we are unable to break down adequate levels of glucose, and so we start breaking down lipids, and the acidic levels rise. And with the rise in these acidic levels, that can also lead to a loss of sodium and chloride. And we'll get to further details on that. I'll just kind of have you mark it there as one of the one of the things that can happen in diabetic ketoacidosis is the chloride levels can drop low. And then addisons, because again chloride and sodium are so closely related. If addisons, I was going to remember addisons is has to do with an inadequate levels of aldosterone. Manifestations are similar to hyponatremia. Slower respiratory activity, that's a real important issue, and again that has to do with the exchange that we were just talking about. And then it also can lead to metabolic alkalosis. And we'll talk more about that condition as well, but that would be a raise in pH due to functioning at the kidneys. The causes of hyperchloremia, if we fail to lose it at the kidneys, in terms of the regulation for it. Dehydration, that would mean that sodium levels rise because fluid levels drop, likewise so will chloride levels. Cushing's being the opposite of Addison, so that's excess of aldosterone. Cardiac failure and hypernatremia. And again, with the cardiac failure, we'll talk a little bit more about how that how that plays a role when we do the cardiovascular disease. So again, this is more one to just mark there. The kinds of manifestations we can see, weakness. This is again similar in symptoms to what you, or manifestations rather, to what you see with high levels of sodium. So again, not focusing too deeply on any of this. This Kussmaul's, or this deep, rapid respiration, this has to do with the fact that you will, with an excess amount of chloride, it interferes with that carbon dioxide exchange process, and you can actually become more basic, and so you have a problem with getting adequate oxygen levels, and the oxygen and carbon dioxide balance is off. I'll deal a little bit more with that even when we come with the acid-base balance. So at this point, again, like with all of the other fluid and electrolyte disorders, this is not, and this is one of the minor ones. I mention it only because of really what's going to be on the next slide. So I put this information out there. There's not a lot of reference point in your book, but I want you to be aware of this term Kussmaul's breathing, or Kussmaul respiration, a deep but rapid respiration. Sort of sounds like a person who's almost hyperventilating, except that it's a very deep breath that goes in. Hyperventilation is shallow. So that's the difference between the two. But I know I'm kind of dancing around the content here because we're going to go a little bit deeper when we get into acid base, and I'm going to bounce back to it. But I wanted to introduce chloride to you, particularly for what we have coming here, which is this bicarbonate chloride exchange, which we'd already went through, and then the next slide, which talks about the anion gap. So let me take you through both of those, and then maybe this will make a little bit more sense, because I kind of feel like after I'm listening to myself give you this lecture, I think I might have confused you a little bit on these manifestations, particularly since you don't have a good reference point in the book. So let me go forward and then see if this doesn't start to make a little more sense. So the bicarbonate chloride exchange, we've already talked about that exchange that is occurring at the red blood cells. So that's back here on our picture here. That was the chloride shift. So you should start to recognize that bicarbonate and chloride have really inverse relationships. They're exchanging all the time. And so anytime we start dealing with a bicarbonate, the way bicarbonate is formed is with carbon dioxide levels. So if carbon dioxide levels increase, then we have more of this shift going on, and it requires that there be a greater shift here with the chloride. And so if I have inadequate chloride, this shift isn't going to go. This isn't going to take place. If I have too much chloride, then it will move all. Nothing's ever supposed to go 100% in this reaction. Some bicarbonate should not make this switch out, but if you have excess chloride, then more of this will shift. This will lead to more bicarbonate in the exercise and raise the pH so that I become more alkalotic. So that's the one exchange. Well, we have this similar exchange going on at the kidneys with bicarbonate and chloride. So chloride will be reabsorbed along with sodium in the presence of aldosterone. That's the normal function. But since both bicarbonate and chloride are anions, they can exchange for one another, and that happens fairly frequently in an attempt to try and balance pH. So if we're in a more acidotic state, then the kidneys will respond by retaining more of the bicarbonate and excreting more of the chloride. Let me say that again. So if we're in an acidotic state where we have more, the pH is low, we need a buffer and we need to raise our pH, then bicarbonate will be retained in greater amounts at the kidneys, and therefore chloride will be lost. Likewise, if we're in the opposite, if we have more bicarbonate at the currently in the blood plasma, then the chloride will be retained and will send the bicarbonate out. So these two switch places frequently in order, and at multiple areas, but right now we're at the kidneys, in order to try and maintain pH balance. So we're actually moving into this pH realm now. Now, I mentioned earlier that one of the common ways to deplete chloride is due to vomiting. When that occurs, we lose hydrochloric acid, and that's one of the main chloride ions. The hydrogen and chloride bind together and make the acids of our stomach. When that's lost, bicarbonate absorption actually starts to increase. And because of that, that is a compensation that occurs due to vomiting. We start to retain more bicarbonate. And so when that happens, we wind up with hypochloremic alkalosis. So the bicarbonate level starts to rise, but we've lost chloride due to the vomiting. So vomiting triggers an absorption of bicarbonate. That's a side effect to vomiting. But what winds up happening is then bicarbonate levels rise and chloride levels are low because of that. So we're in an alkalotic state and the chloride levels are low. Likewise, hyperchloremic acidosis is a decrease in pH due to decreased bicarbonate and increased chloride. So we can see these inverse relationships going on. So this last bullet point here isn't linked directly to vomiting, but what we can see is if we get into a decrease in pH, which means we have more hydrogen ions and less bicarbonate, that we can have a state of hyperchloremic acidosis. So these are buffer situations that can occur. Now, the anion gap is an actual laboratory test that we can use to assess situations with regards to acid-base balance. So the anion gap is the difference between the major cation, it's all of the cations, but sodium is so much greater than any of the others and we're talking plasma, so we're talking about in the blood plasma, in the extracellular space. The difference between the major cation, which again primarily sodium, and the major anions, the negatively charged ions, chloride and bicarbonate. So the normal level, and you don't have to have this value memorized, but you need to recognize that this test is done to look at the normal values, 8 to 12 milliequivalents per liter. If we see an increase in the anion gap, if we see an increase, so you run the test and you see an increase in the anion gap, this is due to lactic acidosis or ketoacidosis. So this is an indicator that your patient is in an acidotic state. But if the patient happens to be in hyperchloremic acidosis, so if the type of acidosis they have is hyperchloremic acidosis, the anion gap will remain normal because chloride replaces bicarbonate in hyperchloremic acidosis. So acidosis, remember, is more hydrogen, which means less bicarbonate. But because chloride is replacing bicarbonate in that exchange process, so if we are in hyperchloremic acidosis, the anion gap remains normal. Right? So that's an important clinical test that you need to keep in mind. If you're given an anion gap value, and I'll give you the normal value, and you see that it's higher, what conditions are you concerned may be going on? Lactic acidosis or ketoacidosis? If I tell you that your patient has a low pH, but the anion gap is normal, you can anticipate that that patient has hyperchloremic acidosis. And so if they have hyperchloremic acidosis, you want to be thinking, okay, well, why is that chloride level high? Well, it's making an exchange. Is it at the kidneys? And we start looking for conditions going on there. So you're not doing full diagnoses. You're not trying to get, try to figure out the whole process here. Try not to get too caught up in that. Just start to identify that this is a lab test that gives you an indicator of the type of acidosis. If you see a patient that has a low pH, and then you run the anion gap test, you can determine, is it lactic acidosis, ketoacidosis going on, or are we having a hyperchloremic acidosis? So you can use that test for that purposes. And that takes you to the end of this lecture.